If you have any questions for him, I really do recommend that you go find him in the halls, because this was mind-blowing to us up here. This was great. Okay, so also our next speaker is Dr. Derek Vanhille. Dr. Vanhille is a Davis County native who is excited to be back in the area after spending years away. He went to the University of Utah for undergraduate studies, followed by Virginia Commonwealth University for medical school. He was in Milwaukee at the Medical College of Wisconsin for otolaryngology residency. Following completion of residency, he worked at Revere Health in Utah County until 2024, where he moved back to Davis County to join Mountain West ENT as part of Ogden Clinic. He now lives with his family in Farmington and is a strong supporter of all things outdoors in the state of Utah. So let's welcome Dr. Vanhille.
Okay. Do I have the slide advancer? Which one's next? That's perfect. Okay, perfect. All right. Well, happy to be here with you today. I'm Dr. Derek Vanhille. I'm part of Mountain West ENT Ogden Clinic. Appreciate the Ogden Surgical Medical Society for asking me to be here, and Dr. Tainter, who knows my brother-in-law and was in residency with him, so thanks to my brother-in-law too. So I'm here with you today. I'm going to talk today about some ENT pearls for primary care, and then the hypoglossal nerve stimulator for obstructive sleep apnea, or the Inspire implant. I unfortunately have no financial disclosures, though I should get paid by Inspire for what I'm going to talk about today. As was mentioned, I joined Revere in Utah County out of residency, and then a year ago I transitioned back to this area, which I'm excited about. I'm from Davis County. And so in going around and talking to primary care doctors and practitioners, these questions are the questions that come up. And so while some of them you may know already and it might be kind of boring, there's 3 parts to the lecture today, so hopefully something in there is of interest to you. And if you're not in primary care, this is like ENT for your family barbecue. So I still get asked, and should rightly get asked, about who mostly are pediatric patients who are candidates for tympanostomy tube placement as well as tonsillectomy. And then just kind of some random questions that come up regarding ENT complaints that, you know, as primary care providers you deal with every day. And then to talk about the hypoglossal nerve stimulator, or which I will just refer to as the Inspire implant, though there are others, that's the one that we use. And just discuss who are candidates for this and the data that supports the use of this, which has not been adopted by all involved. So where do ENT get our information? You know, what guidelines are we following? And so most of that is coming from our own clinical practice guidelines. And so slightly different for adults, but fairly close. For kids, we follow the guideline that was published in 2013 by our academy, and then there was an update in 2022. So the most common reason that we're putting tubes in kids is for recurrent episodes of otitis media. And that's defined as 3 episodes in 6 months or 4 episodes in 12 months. So when you're counseling patients about is it appropriate to consider ear tubes, that's kind of a general tool to follow. That's not necessarily the only reason. And unilateral is one, so if they have bilateral, that's considered 2. The second reason that we look at it is for chronic effusion, so someone with an effusion for over 3 months that may have hearing difficulty or other defined symptoms. And so these guidelines are helpful to in 2 ways. You know, so sometimes there's the parent who comes and they want their kid to have tubes because everyone else in the family had tubes and they should have tubes, and they've had one ear infection. So it's nice sometimes to say, well, here's our guidelines, and maybe let's wait for Billy for a little bit and see if he actually needs it. And it is also helpful sometimes for the parent who wonders, you know, my kid's had 7 infections, and should I do it, and is that the right choice, and am I being a good parent by, you know, having them undergo surgery? And then you give them the guidelines, and it helps them feel a lot better about that. So if they don't fall nice and neat into some of those categories, there are other indications to consider surgery and to place tubes, and some of those, as listed in Table 2 there, developmental issues, autism. Obviously, if they have a known hearing loss on one side or blindness, kids with clefts often are getting tubes at some point in one of their surgeries. Or just some learning disorders or concerns about their hearing overall. We don't necessarily have to wait for 3 months if it's been a month. And I saw a kid who had congenital atresia and really can't hear that well from the one side and had an effusion on the other side. Well, I don't think we need to wait 3 months for that. And for him, that's obviously important that he hears. Tonsillectomy. So tubes and tonsils, right, some of the most common procedures performed in the country. And again, just because I'm getting feedback from primary care, what is the guideline that you follow? Are you still following the Paradise criteria, which I'll get into in a minute, which is funny, the Paradise criteria. So again, our clinical practice guidelines from 2011 with an update in 2019. So this is primarily focused for kids. The main reason that's common that we're seeing kids undergo tonsillectomy most of the time is related to sleep disorder breathing as well as the recurrent tonsillitis. Once you get into the teenage stage, then there's more of that chronic tonsillitis and tonsil stones. And I think what's challenging for some people is if you don't have tonsil problems or never had a kid with tonsil problems, this doesn't seem like that big of a deal. But if you've had personal issues with that or a family member that have had issues with their tonsils, why do we keep talking about tonsils, right? Well, because it's a big deal. So depending on which academy you are a part of, you may or may not support doing a sleep study in pediatric patients. For ENT, we don't support necessarily that you have to have a sleep study as a pediatric patient in order to have the diagnosis of obstructive sleep apnea. So looks like a duck, talks like a duck, walks like a duck, is a duck. So a kid that has 3+, 4+ tonsils, parents say they snore every night, they have videos, they show you their kid stop breathing, is this normal? You're like, no, that's not normal, it happens every night. A sleep study may not change what we're going to do, right? So order the test if it's going to help you. But there are definite people that, pediatric patients that are candidates and potentially should have a sleep study, especially if they're under the age of 2. Down syndrome, other craniofacial abnormalities, neuromuscular disorders, or oftentimes when their physical exam doesn't necessarily match their symptoms. So they have all these symptoms per parents and their tonsils are 1+ or 2+, average size. Then a sleep test may be helpful then as well. It's kind of the second indication that we see is for recurrent tonsillitis. And yes, we are following the Paradise criteria, which I will get into, which is funny because of when it came about and how many patients were involved. But the reason we follow it is because it's like dogma everywhere. And this is what insurance companies follow as well. So that is 7 infections in 1 year, 5 infections for 2 years in a row, or 3 infections for 3 years in a row, with associated symptoms of fever, cervical lymphadenopathy, exudate, et cetera. Doesn't necessarily have to be strep positive. And so I know you're seeing these patients and you're like, well, they've had 4 for the last 2 years. Are they candidates? Well, that's where obviously we got to decide what's clinically relevant and what's not. Another reason is for chronic tonsillitis, tonsil stones, and cryptic tonsils. Patients that come in with tonsil stones and history of long tonsil stones, I tell them there are 2 types of patients who have tonsil stones and patients who don't. And those that have never had a tonsil stone, myself included, I still have my tonsils, they're 2+. I've never had a tonsil stone. Unless I talk to patients all day about tonsil stones, I'd be like, what is the big deal? But it can be really debilitating to people. I most recently did a surgery on a lady who's a school teacher. She knows that her breath stinks from her tonsil stones. It makes her very self-conscious talking to her students. It's disrupting her life. That's another reason to consider that when they have this recurrent or cryptic or chronic issues with their tonsils. Now, the Paradise criteria, nothing against the study at the time, but this is used everywhere. And in every aspect of medicine, there are these studies and these things that are followed that we're like, why are we still following this? And we are. This was from 1984. That was the year I was born. So we're still following this guideline that, again, was in the New England Journal of Medicine. It's a great study, but we have lots more data now to come up with better guidelines. That's why I say if they're not following the Paradise criteria per se, it's all right, still send them, let's talk about it. So this was 187 total patients. Only 91 were randomized, and the other 96 were non-randomized according to parent preference. So there were 41 surgical candidates and 48 non-surgical in the randomized, and the parent preference 52 to 44. So it's not a big study. They recruited patients over 11 years, and 25% of them didn't have follow-up after 3 years. So it's not a knock on this study. Obviously, it was a great study at the time, really to look at who is it relevant to do tonsillectomy for, but it was a randomized study of basically 50 patients in each arm, and these are the guidelines we still follow. So this is just one. This is just Anthem. This is just their guidelines. You can see there at the very top. That's the Paradise criteria. So based on the study from 1984, that may or may not be relevant in our day, or if we have lots of data, which I'll go over for Inspire, a lot more data for Inspire than we do for this, but that's still followed. That is why we still follow it, because that's the dogma, but obviously not every patient fits nicely into that. To move on real quick for a couple of ENT pearls. So this is as I'm going out and visiting and talking with different providers, and just some questions that they ask me. Again, this is kind of the second part, and the third part will be Inspire. And I guess, for you out there, most of the time you don't think you have ADD until you're sitting at a conference during a lecture and you're like, I think I have ADD. I cannot pay attention, right? So the first part is over. If that part isn't relevant to you, just some quick pearls for you, and then we'll get into the Inspire implant to hopefully help with that feeling that you have ADD. Ears. And again, this is just because we're getting information from you, or what do you do about this? Itchy ears is a common thing. I recommend mineral oil or olive oil. Also keep in mind it can be allergic. They can have itchy ears because they have allergies. If they itch their ears a lot, that can break the skin and then lead to otitis externa, and then we're seeing them for that. Earwax, this is, one of the most common things I get asked about, at my own family barbecues, right, is earwax. So what do you do, and how do you get it out, and what if I'm not supposed to use Q-tips, but then what do I do? The body naturally pushes the wax out. When you use a Q-tip, you push it in. Some people that are higher risk, obviously those that wear hearing aids, those that are putting a lot of things in their ears like earplugs for work or things like that. So Debrox or Debrox drops over the counter can be helpful. Mineral oil is helpful. Not everyone loves irrigating the ears, and so if they don't like that or they've had problems before, just send them to see me. It's, while I don't want to clean ears all day long, it is actually very gratifying because they come in with a problem, they leave with a solution. So happy to do that. Tinnitus or tinnitus or ringing in the ears, this is a challenging one. There is no fix for it, meaning there's no surgery, there's no pill, there's nothing that fixes that, but we do talk about behavioral modifications and do a hearing test, because oftentimes, not always, but usually it's associated with hearing loss. And with that, I just wanted to just put in a plug for hearing, that our guidelines just recommend that patients over the age of 50 just have a screen for hearing loss. And that could be as simple as you asking them. You don't have to do a Weber and Rene tuning fork test, but just asking if they feel like they have hearing loss. And if they do, then send them, as it says, recommend sending to someone who can do a hearing test or do an audiogram. Whether or not that's with us or at Costco or whatever, it doesn't matter. Just send them to get a hearing test. If you don't have hearing loss, then you don't understand why hearing loss is a big deal. For the nose, real quick, we love our nasal steroids, but many people come and they've used Flonase for 3 days and it didn't help. This is because it's not going to. It's not Afrin. Afrin helps in 3 days, but Flonase or any of the intranasal steroids are going to take time. So I usually tell my patients it takes weeks. It's like weightlifting. If you lift weights for 3 days, you're not going to notice a difference. You got to do it consistently to notice a change. Over-the-counter antihistamines, azelasin, which is Astelin, or Astapro is also over-the-counter as Astapro. There's Pataday eye drops, and then I don't know who loves nasal rinsing more, our patients or ENT, but we love nasal rinses. Won't do a raise of hands. It's kind of like drowning, but it works very well, and it's very effective, especially this time of year. I don't think that you think turbinates are polyps, but your patients often think turbinates are polyps. So when they look in their nose and they see that and they have polyps, it's just a turbinate. Then the other thing that we see commonly is mucus retention cysts, which are usually in the maxillary sinus, often seen on a dental film, don't require surgery. It is a rite of passage for every ENT to put a scope in their nose at some point and look down their throat. This is not me, but I have done this before, and to evaluate the vocal cords of the voice box. So we have one picture there that shows normal vocal cords, and then we see something very concerning there on the other side. So just in regards to who do we send, for voice complaints, anyone that you want to send is fine, but obviously if they have a strong history smoking and drinking, happy to see them, and they should be evaluated and looked at. Flexible laryngoscopy is done easily in the office. It's well tolerated, and I say that because I've had it done many times by medical students years ago, and I did fine. I'm still here. So it's tolerated very well. Voice changes, often in elderly, usually related to atrophy. There are options for them, even doing augmentation in the vocal cords with similar products that we use for facial filler can be helpful. And then chronic cough and chronic throat clearing. I lived next door to a chronic throat clearer my whole life. She didn't really have a medical issue. She had a habitual issue, and a lot of them are, but there are other things to look at. Speech therapy can be helpful, neuromodulators, and even low-dose opioids can be helpful as well. Neck masses, a question I often get is, do you want imaging before we send them to you? Do you not want imaging? Either way is fine, ultrasound or CT, and you know the reasons that either one can be helpful. We're happy to order imaging as well. FNA, you can order the FNA before for anyone, that's fine. They still may need an excisional biopsy if their results aren't conclusive. And then for thyroid nodules, don't forget to order genetic testing. The two common tests are Afirma or ThyroSeq. And most facilities, we as ENT and the surgeons are working and endocrinology to kind of get this as the standard, that if you order to a test somewhere, that gets automatically done. And the reason why is there's a lot of great data that's very helpful in deciding who are surgical candidates related to thyroid nodules. So ADD, we're going to move on, right? So we're going to talk about the hypoglossal nerve stimulator, or the Inspire implant. So I'm just going to refer to it as Inspire. And so you may have heard of the Inspire implant. I make fun of the Inspire reps and tell them, there's a lot of commercials out there, and usually when there's a lot of commercials, something really isn't that good of a product. They're pushing it a lot, but Inspire really is a great product, and we'll look at the data that has a lot better data than the Paradise criteria that goes over the Inspire implant and why it's helpful. But what is it? So essentially, it really is a stimulator lead that is placed on the hypoglossal nerve, which stimulates the tongue. There is a sensor and the battery that is about the size of a pacemaker that's put in the upper chest, and senses when the patient stops breathing. And then it sends a signal and stimulates the hypoglossal nerve and pushes the nerve out, or protrudes the tongue. So it physically opens the airway instead of positive pressure opening the airway. So yes, it does in fact push the tongue out. No, it doesn't make people look like a frog. And no, it's really not that stimulating for them, and they don't notice that at all any more than you would notice CPAP at night. So who are candidates for the hypoglossal nerve stimulator, or Inspire? And this is an area that is interesting because we just visited with a sleep provider earlier this week, and there is a difference of opinion, right, of who should have this done. And it isn't necessarily the gold standard, but people who come to see us aren't, the gold standard isn't working, or they don't want to do it, and that is CPAP, right? So who are the candidates for this? The FDA indication is down to age 18, but some still, and this is just kind of a summary of different insurance companies, some are still kind of over the age of 82, AHI of at least 15, and then only less than 25% of central or mixed apnea. Obviously not going to be that helpful if it's a central apnea, if that's 50 or 80%. BMI, and this is the max BMI, up to 32, some up to 35, some up to 40, and even the sleep provider yesterday was saying, well, I think it's less helpful if their BMI is 38. Well, it really just depends on what their throat looks like, and that's what you're seeing on the side there, and that's from a drug-induced sleep endoscopy. So this is putting the camera in the nose and then looking just at that junction of the nasopharynx and the oropharynx where you see the soft palate, the side wall, and the posterior pharyngeal wall. So if they have a lot of anterior-posterior collapse, whether or not their BMI is, 30 or 40, they may be a good candidate versus concentric collapse, and you don't know that. You send them to us and we do sleep endoscopy, but all that to say the BMI requirement. Some need a sleep study within the last 2 years. I think Select Health is the only one now that is requiring failure of a mandibular device. And then CPAP intolerance, which is also defined differently by every insurance company, whether or not it is intolerance or just flat out refusal, different, but less than 4 hours a night for 5 days a week, or inability to reduce OSA with an AHI less than 15 by using CPAP. And then, again, no evidence of concentric collapse on drug-induced sleep endoscopy. So I wanted to put lots of really nerdy videos in here about us dissecting out the hypoglossal nerve, but potentially me and Dr. Anderson think that's fun. But this is the hypoglossal nerve there in the middle. That is showing on the right side what the lead looks like that gets wrapped around the nerve. And then you don't have to remember all the muscles of the nerve, but just we're preferentially activating the genioglossus and geniohyoid. So you think about where those attach. As they activate, it pulls the tongue forward, and you want to exclude the branches that pull the tongue back. So I would show you all the nerdy videos, but only I would think it's fun right now. But essentially, you get the hypoglossal nerve, you dissect around it, and then you put that lead or that cuff onto it. And we're dissecting out certain branches of the hypoglossal nerve, again, those branches that protrude the tongue instead of bring the tongue back. You then activate that during surgery. You can actually watch where their tongue moves, and you have leads in the different branches so that you kind of know that you're activating the correct branches. So again, that then activates and it pushes the tongue out. So I do think UPPP or uveolopalatal kind of, ENT, we shot ourselves in the foot by saying, everyone gets UPPP and it cures sleep apnea, right? You may have had it, you sent patients for it. My dad had it, didn't change anything for him. And UPPP is still very helpful. It's still a tool in the toolbox. I still do UPPP, and there's a reason for it. But Inspire implant is not UPPP, and there is a lot of data to support its use. And when we talk with certain sleep providers that are very much against it, we're not trying to steal, everyone and say, everyone should get Inspire, right? Most of the people we're seeing are the people that aren't doing CPAP anyway. So they're already not doing CPAP. They're not treating their OSA. They're having long-term complication or consequences of that. So we're not trying to, take over the world and do Inspire on everyone, but provide an option for people that currently aren't treating their sleep apnea. New England Journal, great journal. Even though the Paradise criteria from 1984 was from the New England Journal. This was from the STAR trial, which was the original trial that looked at this, and one of the locations that was the original trial site was where I did residency with Dr. Woodson. So this was published in 2014. This was the first study just showing, really the proof of concept, and there have been many studies since, but there were 126 adults with moderate to severe sleep apnea. They all had CPAP non-adherence, and they looked at a number of different things, and we can look at, that whole trial, but just kind of some high-level things. The AHI reduction was a 68% decrease, and ODI reduction in 70%, so you can see from 29 events to 9 events an hour, and the Epworth sleepiness score improved to less than 10, and that's normal. The AHI increased in the withdrawal group, and so those that didn't end up with the proceeding with that, they had symptoms. So 2024, fast forward the systemic review and meta-analysis. So this is looking at 44 studies with over 8,600 patients with a follow-up for 12 to 36 months. So they looked at all these same things to say what is the benefit of the Inspire implant. And at 12 months post-treatment, 47% of patients achieved AHI less than 5, 72 achieved AHI less than 10, and 82% achieved an AHI less than 15. Their Epworth sleepiness scores reduced from 11 to 5, and then even quality of life scores. So again, obviously for a patient to tell them what their long-term risk for heart and lung disease is somewhat helpful, but most don't care. They just care about what's happening right now in their everyday. And that's their mood, that's their energy, that's headaches that they wake up with in the morning. And if they're not using CPAP anyway, right, what is the benefit here? And so the study showed a 25 to 40% improvement in even the generic quality of life assessments. To follow up on the STAR trial, so this was published in 2018, kind of a follow-up from those that were in the original trial. This is showing the AHI before Inspire at 29 and after at 6. This is a big deal, right? Many people come in because someone says they're snoring, they're not bothered by it, but it affects their bed partner. And so snoring, which we don't do Inspire for snoring, but that is a big deal, and that brings people in. You can see before and after. Also looking at what's called an adhere registry to kind of look at what's happening long-term with patients. And this is currently, this one was with 508 patients. This is how many hours a night they're using it, which is 5.7 at approximately 12-month follow-up. And then just overall here, just looking at, how does Inspire compare to previous CPAP? Would you recommend Inspire to a friend? I would do Inspire again. Overall, how satisfied are you? The dark green is strongly agree, and then the light green is agree. And so this is with, a large number of patients, close to 400 patients, those that are happy with it, obviously, that they had it done. So the hypoglossal nerve stimulator, again, nerd alert, fascinating concept, stimulating the hypoglossal nerve. The surgery is very well tolerated, and it works, right? So there's data that supports its use as well as patients like it. And newsflash, they're not using CPAP anyway, so we're not stealing them from the sleep providers. Those in Davis and Weber County, depending on which tribe you belong to, Ogden Clinic, Tanner Clinic, or Intermountain, the different providers at each location that are doing the Inspire implant. So with that, I appreciate your time, and I don't know if we have time, but potentially take any questions. Yeah. Question? No? Okay.
Yeah, I got one question. I've been told that chronic reflux was the cause of the you call it throat clearing, and it's noted to be occurring about 10 minutes, 15 minutes after eating. Do you have any comment about that?
Yeah, so I think reflux and postnasal drip are common reasons patients complain of chronic cough, and so we always want to at least treat that first, right? So let's remove any inciting events, which reflux can be an event that creates that, or postnasal drip. Let's decrease that, then work on some of that habitual nature as well and see if that improves over time. But yes, definitely reflux is a cause of chronic cough.